Good afternoon and welcome to this webinar about implant dentistry. I hope all of you and your families are fine and safe in this very singular moment of pandemic. With this speech, I would like to give my small contribute for cultural improvement in this critical moment for our society. I especially want to give thanks to Clocker Company for having organized this event and for having invited me to participate in it. My name is Matteo Albertini. I'm professor of EFP Master of Periodontology and Implant Dentistry at International University of Catalonia in Barcelona. And I developed my clinical practice mainly at Barcelona Dental Institute as a periodontist. And the topic of this presentation is minimally invasive guided bone regeneration for implants in aesthetic areas. So let's go with the presentation. I would like to stand out that all the cases I'm going to present have been restored by my friend Roberto Padros. Hello, Roberto. So, we have to understand the different biological response of the periodontal tissues to dental implants. So it's not the same to have an implant or a natural tooth, because we do know we're going to have a shrinkage of these tissues after dental extraction. But the objective of implant treatment is to reestablish, to give back to the patient the function and the aesthetic. So we have to know very well the biological behavior of these soft and hard tissues. And these biological changes start right here, in the moment of dental extraction. We do know that after extraction, we're going to experience a shrinkage of the crest, more or less 3-5 millimeter horizontally and 1-2 millimeter vertically, if we have entire bone walls. But in many cases, like in this case, we have to take a different situation in which we don't have buccal bone. And in these cases, we know that we have large dehiscences. When we have large dehiscences, we're going to have a big shrinkage of the bone and soft tissues in this area. So we have to rebuild these tissues.
Disculpe, doctor Mateo, creo que tiene uno de los controles de Keynote encima de la presentación y lo vemos. Si lo pudiera cerrar.
Deja de id.
¿Vemos lo de gota de agua?
De agua. ¿No?
No, se sigue viendo. Ese es un panel justo encima a la derecha. Quizás
Mateo,
sí.
Mateo, son las modificaciones del Keynote, que se ven a la derecha del Keynote.
Eso es.
Okay. So you don't see. So if I reproduce my presentation, don't you have a full screen here?
It's Mateo. It's the Gmail. So close your mail, please.
My mail.
Yeah.
No, try to. Dele a reproducir ahora, por favor. Eso es.
Try right now. Try right now. Please.
No. Okay.
Please unshare your desktop, please, and share it again. So
Okay,
leave it
okay.
and share it.
Okay, let's try to repeat. So desktop. Let's see.
Not exactly the same. There's
Okay, let's try again. So, compartir pantalla, Keynote. Keynote. Let's try with share Keynote.
Okay.
right now.
Okay, perfect.
Okay?
Yep.
Yeah.
Okay. I cannot use the pointer, but it's okay. Okay, so I was saying we have large dehiscencies and we have to compensate these dehiscencies for implant treatment. So mainly in the clinic we have two clinical situations. First one is the dentulous area in which we have already lost the tooth, or we can have the opportunity to extract the tooth. If we are in the first scenario, like in this case, we can see we already have a big shrinkage of soft and hard tissues in position 1.1. And we have to deliver a good aesthetic in this case. To do that, we know that a full thickness flap and flap elevation is needed to create a space to regenerate the bone and the soft tissues. So in these cases, we have no other chances to make a bone regeneration, and in this case, in one shot, soft tissues augmentation as well. So this is not minimally invasive. We have to advance coronally the flap. You can see we have a releasing incision distal to the 1.3, and we have to wait a couple of months. Only after 6 or 9 months, we can provisionalize the patient and start conditioning the soft tissues. So after the conditioning of the soft tissues, that is 1 or 2 months of conditioning, we can have this good shape of the soft tissue with a good thickness, thanks as well to a very small platform of these implants. It's a Vega implant. And finally, we can restore the case. But we can have in the clinic also a more advanced situation, because we hadn't the opportunity to extract the tooth. And in this case, we already have the implants placed. And we have a big discrepancy between the mucosal margin of the 1.4 and the rest of the teeth. So, you know, we can give back aesthetic to this patient, but this is not easy. We have to use a vertical bone regeneration procedure. This is not minimally invasive, and then periodontal plastic surgery as well. We can get nice result, but this is not cost effective and time consuming with a certain degree of morbidity. Here we can see when we are removing the non-resorbable membrane, and now we have the bone availability to put the implants in the correct three-dimensional position. 2 implants in the 2 premolars. And then we have to manage the soft tissues. This was the beginning situation, and this is the situation before. You know, this is possible, okay? But this is not easy, and as I said, is time consuming, not cost effective, and with a certain degree of morbidity for the patient. So in the second scenario, we have an hopeless tooth to be extracted, and we have the opportunity to manage both hard and soft tissues. So we can have two different possibilities. We can have favorable cases and less favorable cases, depending on several factors. But here, I want to focus on the two most important factors we have to, parameters we have to respect this, the gingival margin position and the bone crest position. If we have an alien type 1 with no bone loss and a coronal position of the gingival margin according to the future restoration, we are in a favorable situation. So in these favorable situations, we only have to preserve the tissues and also to put the implant in a good position, the perfect three-dimensional position of the implant. And to preserve the tissues, we do know that it's not enough to put the implant. And in most of the cases, we have to use soft tissue graft and as well particulate bone substitutes. So in these cases, it's pretty easy to get nice aesthetic results with the full fill of papillas and to deliver a restoration that is similar to a natural tooth. Here we have the radiographic control after 2 years with maintenance of the bone level. We can use this technique as well in less favorable cases with bone defects, but we still consider this a favorable case. We have a bone defect, but the soft tissues are very good, in a good position. We have to consider we have an abfraction and a small recession on the tooth 1.4. So same protocol, it's a flapless technique. We extract the tooth, we position the implant in a palatal position, we graft the area with a soft tissue graft from the palate, and we insert the graft within an envelope. It's a tunneling technique. Then we have to move coronally the tissues to cover the recession at 1.4. And this is the position of the implant and the radiographic image of the implant. So this is the situation after placing the provisional restoration after eight months from the implant placement. And finally, we delivered the final restoration. And you can see in these cases, we can achieve nice aesthetic results. And here you have the radiographic control and the follow-up at 1 year. But if we are in the second scenario, less favorable cases, less favorable because we have some loss of maybe soft and hard tissues. We can have a type 2 or type 3 situation. Type 3 if we have a gingival recession. And we have to distinguish a little bit between the type 2, A, B, and C. We can have even a complete loss of the buccal bone in the 2C. So what do we do in these situations? We can use different approaches. We can intervene and regenerate the tissues immediately, or use an early approach after 4 or 8 weeks, or even a delayed approach in which we have a mineralized bone and less regenerative space which has to be created. So I want to focus the presentation in the immediate approach in which we have an open wound, only the blood clot, but we have a big regenerative space which has been created by the root itself. I want to introduce you this protocol. This is an immediate softened hard tissue alveolar reconstruction technique in which we position a membrane without raising a flap. Then we fill the space between the bone and the membrane with the biomaterial. And then finally, we insert a soft tissue graft to stabilize the wound, to close hermetically the crucial part of the socket, and to increase the soft tissues. So I'm going to show you a small video about this technique. This video has been supported by Klockner and Botis Biomaterials. So we have to extract tooth 1.1 with a totally loss of the buccal bone. So we extract the tooth and we have to create an envelope. It's a full thickness envelope. We have to remove the granulation tissues inside the bone defect. So we enlarge a little bit the tunnel. And then we insert a resorbable membrane. This is a pericardium resorbable membrane. And we have to reshape the membrane according to the bone defect. We can put the membrane by means apical sutures with horizontal mattress. We can use 1 or 2 sutures, and in some cases, we can even introduce the membrane without suturing. So we fill the space between the palatal bone and the membrane with the biomaterial. Here we are using Cerabon from Botis. And finally, we graft the area with a soft tissue graft harvested from the pellet. We use generally only 1 apical suture just to insert the graft, and then we put some simple stitches. Only after 8 months, we perform the implant placement with a transmucosal approach because we don't want to touch papillas, and we put the implant. Here we're using a Klockner Vega implant. And finally, we can even immediately load the implant or wait for 6 weeks to load the implant. So here we have the same clinical case. This is the 1.1 with the loss of the buccal bone. So after having used the technique, we put generally a Maryland bridge, and then we wait for 8 months. After 8 months, we put the implant transmucosally. Then, generally we wait 6 weeks and we restore the case. This is the restoration by Roberto Padros. Here we have a 1-year follow-up, and you can see a nice soft tissue contour. And here we have the 2-year follow-up of the case. And we can see that the interproximal bone has been maintained. So we can treat even worse cases with this approach. We have tried this technique in this case as well. We have a gamma smile and an apical fistula. So in the CBCT, we can see that we have a totally absence of the buccal bone. There is an horizontal fracture of the tooth, and even we have a big nasopalatine cyst, as you can see in the occlusal image of the CBCT. So in this case, we have to elevate a full thickness flap palatally to remove the cyst, and then we use the same technique. Here you have the cyst and the rest of the tooth. So we insert the membrane within the buccal envelope. We fill the space with the biomaterial. And in this case, we have to use a big membrane to cover the palatal window of the cyst. Then we graft the area with the soft tissue graft, and we stabilized the wound with the suture. Here you have the situation after 8 months, and it seemed to have nice bone availability. So after 8 months, we go and put the implant with the transmucosal approach, avoiding touching the papillas. And then we start the provisionalization. And finally, we restore the case. And here we have the 2-year radiographic follow-up. So here we have a different case. This is alien type 3, in which we have gingival recession. The tooth 2.1 had an invasive cervical lesion. So the tooth was not maintainable, as you can see in the CBCT, and we have a partial loss of the buccal bone. In this case, we decided to put the implant as well and to do the surgery all in one shot. So we put the implant, we made the same protocol. This is the situation after conditioning the soft tissues with the provisional restoration. And here we have the final delivery of the definitive crown. You can see how the bone is maintaining. So I want to shed light on the scientific evidence of this kind of approach. And I have to say that about immediate bone and soft tissues augmentation in post-extraction site, we have several papers, but mostly we have case series, case reports. Lately, we have an interesting paper from Alberto Sicilia of 2020. It's a case series of 40 patients, but we can say that all these trials show improved aesthetic outcomes but the scientific evidence is still limited. So I can show you other cases. This is a 2.1 restored by Dr. Anna Karpova with the same protocol. So no incision, no scars, and in this case was all in one shot. Another case, this is a periodontal case in which we don't have the buccal bone, as you can see in the CBCT. The same protocol, the implant after 8 months. This is the final delivery of the restoration of the cuspid with a nice aspect of the soft tissues. And here we have a follow-up after 2 years, a CBCT, in which you can see the presence of the buccal bone wall. So, going back to the first clinical case, I want to show you that it was easy to get bone availability at the coronal part, but you can see that the position of the implant was not perfect, because at that time we didn't use the totally guided surgery, and it is very advisable to do it. We have 9.5 millimeter of bone availability. But as I said, we have to treat these cases. My advice is to treat these cases with guided surgery, because we are more precise with the position of the implant. Like in this case, here we have a type 3 socket. We treated this case with immediate loading procedure, and here you can see the final restoration. In this clinical case, we have the loss of the buccal bone and even partially the palatal bone because of vertical fracture. So we apply the same protocol, the membrane within the envelope, the soft tissue graft. And this is the ridge aspect after 8 months. This is the CBCT after 8 months. This looks nice. And then we plan the implant position by means the exoplan software. And we can see that the implant is totally rounded by bone. So it's pretty much easier to put the implant with the guided surgical protocol. So I want to show you a clinical video of this technique. Here we have to extract the tooth 1.1. You can see the absence of the buccal bone wall. So we have to remove the granulation tissues very carefully. You can see the probe. Okay, so we have to create an envelope. So we tunnel the area, and we have to check that we have enough space for the membrane and for the soft tissues. So we prepare the implant bed in a palatal position, and we insert an implant. This is a Vega Plus implant, and we have to check 3 millimeter distance between the implant shoulder and the gingival margin. Then we put an healing screw, 2 millimeter of height, and we insert the membrane. In this case, it was very, very easy. So we didn't put sutures. We fold the membrane buccally, and we start filling the space between the membrane and the implant. Here we're using the strata bone. It's bovine bone. And then we harvest the soft tissue graft from the palate with the extra orally desepitalized technique of the free gingival graft. So we have to desepitalize the graft very carefully. This is a very stable tissues, very white and stiff. So we have to be careful and to insert this graft externally to the membrane and internally to the flap. And we use this suture. This is a 5-0 suture. So we fixed the graft apically with 1 stitch. Then we need other 5 stitches. One is in a palatal position, and other 4 stitches at the angles. This is a 7-0 suture. Okay, so now we have a bone defect that is filled, and we have a very, very stable wound. I want to finish my presentation with this clinical case because I consider it is a quite challenging clinical case. So we have the tooth 2.2 in an apical position. This tooth is ankylosed, and we have an invasive cervical lesion class 4 on this tooth. And we also have gingival recession at tooth 2.1 and loss of attachment, the loss of papilla distally to the tooth 2.1. In the CBCT, you can see that the tooth is not maintainable because the lesion is through, and we have a very, very, very thin buccal wall. So we decided to treat this case with the same approach. We performed the extraction and we checked the extension of the lesion that was through. Then we checked the distance between the bone crest and the future contact point. That is 10 millimeter, and it's not possible to have predictably papilla there. And we have, this is the position of the buccal bone crest. So we used more or less the same protocol, but in this case, we elevate an envelope flap by raising papillas because we wanted to advance coronally the flap because we had gingival recession at the central incisor. So we insert the soft tissue graft, we fill the space with the biomaterial, coronal advancement of the flap. We stabilize the wound with another suture of 7-0, and then we wait. We wait for 8 months, and this is the result on the CBCT after 8 months. So we decided to put the implant with the transmucosal approach. This is a Microvega, it's a 3.0 implant that is very good for lateral incisors. So no incision, no releasing incision, no scars. This is the situation after conditioning the tissues with the provisional restoration. And this is the final delivery of the definitive restoration. We can compare the situation before and after, and we can see that with not a big effort, we can reach some acceptable results. Here we have the radiographic control after 1 year. And we can see the position of the implant that is correct. And you can see the clinical picture after 1 year. So, I would like to give you some take-home message of this presentation. So, I want to tell you that this immediate soft and hard tissue alveolar reconstruction technique is a minimally invasive procedure for bone and soft tissue regeneration of alveolar defects, which is an alternative to the early and delayed guided bone regeneration protocol. I can say that in our hands, promising results have been observed from a clinical point of view for single implants in aesthetic areas. In case of moderate and even severe dehiscencies of alveolar buccal bone. But I have to say that to do this, we need some clinical experience to tunnel the area, to harvest the soft tissue graft, and to have good results. And as well, I have to highlight that we still have scarce scientific evidence of this kind of approach. I would give you my Instagram and Facebook account. If you like, there you can see some clinical cases and some clinical tips that may be useful for you. And you can write me there if you need some tips, and I would answer. So, thank you very much. Stay safe.
So thank you, Matteo. Congratulations for the presentation. I think it's very nice presentation and a very nice lecture of discussing about the advantages of your technique. Like, I think that it has so many good advantages in my way of thinking. There are many questions of the public in this issue. So go for the first one. One attendee asked if what do you think about the using allograft instead of xenograft for the socket filling in these cases? What is your clinical point of view? And also the evidence.
I have to say that other biomaterials can be used in these cases, and even autogenous bone. But why we use this biomaterial? Because this is a very good space maker. Okay, it's not resorbable, and as you can see, the biomaterial here is the one who can absorb all the forces, because in the anterior area there's a tendency to the collapse because of the force of the muscles. So maybe this protocol is working as well with allograft or even autogenous bone, but I have not tried, because I prefer to use a non-resorbable material, because it's a very, very good space maintainer.
In this case, I would like to add something from the evidence to answer also this question and to help you to add more evidence about. In this case, there are many articles in which they discuss the use of xenografts and the use of allografts or autogenous bone. And as you have stated before, with the saying that the contraction of allografts, or for example, also autogenous bone, there's so much contraction in a horizontal way and in vertical way compared to the xenograft. So in these articles, in this systematic review, they stated that the best material for socket preservation and for doing this kind of procedures, that the xenografts should be the gold standard, as you have mentioned and as you have stated. So go to the next question. So one attendee said that ask if do you have experience with the use of PREF membranes to avoid the soft tissue graft in the balloon technique?
Okay, thank you for the question. It's a very interesting question. But personally, I have no experience with PRF. I have no experience. I know from the literature that lately have been observed very nice results by using PRF as a membrane, but I haven't used in my clinical practice. And so far, we have used only this kind of membrane and this kind of biomaterial. So I don't know if this is working with other biomaterials. From a clinical point of view, I have clinical images, I have CBCTs, but no histological evidence, you know.
Exactly. So that's the answer, the really good answer to this question. Also, because the lack of soft tissue, as the cases that you have presented, I think that the PREF is not a good scaffold or even a good solution for having or for gaining more soft tissues if you don't place a really good connective tissue graft in this way.
I think
so.
That nowadays the connective tissue graft harvested both from the distal part of the palate or tuberosity is like the gold standard of soft tissue graft. So if you're gonna tackle advanced cases, I think it's better to use nowadays this kind of soft tissue graft. Then research will say exactly if it's possible to use PRF.
Exactly. So really good answer. If you want to add something, Fadi, also you can say something if you have more science to share with us. There is another question linking to the connective tissue graft. I think that you have stated in the last answer that the connective tissue from the tuberosity should be the gold standard, or from the posterior side of the palate. However, some attendee asked if the pedicle rotational flap could be more predictable in such cases that you have presented.
I have to say that I have used this technique of pedicle soft tissue graft with good results. But what I want to highlight is that this technique is more difficult to control, and more difficult to control as well the thickness of the tissue you are harvesting. And finally, I decided to use simply not a pedicle soft tissue, but the free connective tissue graft, because it's easier to get what you know. You can choose where to harvest the tissue, If you prefer, because it's more dense, we have less submucosa in the posterior area of the palate, you can choose to harvest there, and then you can get the thickness that you want. Because if you have a very, very thin biotype, you can even harvest a little bit more. If you have a very good biotype, you need a very, very thin soft tissue graft, because this graft over time generally improves their dimension. They start to grow. So I think the pedicle tissue graft, it's interesting technique, but it's difficult to control the thickness and the quality of the soft tissue graft.
Exactly. So going through the last question, because we are in time, but we don't have to delay so much the next presentation by Fadi Abiyama. So some attendee asked for the trimodal approach in those cases. Why don't you perform a trimodal approach? It means that if you have a flapless technique, also in combination with implant placement, immediate implant placement, and also the restoration. Why don't you place the restoration at the same time of the implant placement and also this kind of surgery?
Okay, so the big advantage of placing the restoration is the support of the soft tissues. So the restoration could be part of the stability of the wound. That is important. Every time you decide to perform immediate loading in an anterior tooth, you are taking some risk. So we take some risks sometimes, but generally when we have sockets, like sockets you have seen, like type 2C, type 2B, type 2C, I think that in all the cases, put the implant and the restoration, it's a little bit risky, because you can lose the implant, or even you can have some not nice results with an implant already integrated. So we prefer this approach in these advanced cases because from a clinical point of view, it's safer. So you rebuild soft tissue, you rebuild the bone, then you only have to put the implant. And nowadays you can put the implant with the surgical guide, with the guided surgery. It's very, very easy nowadays. So the trauma of putting the implant, it's a very, very, very low trauma. And I think you are safer if you avoid immediate loading in very, very advanced cases. As you have seen during the presentation, we have some cases with immediate loading, but we still have some buccal bone. You know, it's only to be safe and prudent.
No, I think I fully agree with you. I think that there also should be more advantages to go for the transmucosal implant placement, because you can model your soft tissue in better conditions than if you place the implant immediately in this kind of cases. I mean, not always, but I did this kind of cases. Doing this approach and delaying the implant placement, or even delaying the implant loading, or in these cases are, I think, crucial, because you can model your soft tissues better, as for example, your last case of the intruded or the ankylosed lateral incisor. That is crucial. In this case, not to go for the implant placement and go for the reconstruction first, and then go for the restoration.
And
I
we can also highlight that to put the implant, you need a favorable position of the root within the socket. And we don't have in all the cases this situation. In some cases we don't have. And mostly we have type 1s, can type 1s, but we don't have in all the cases. And another things I want to add to this question, there is a very interesting question that, as you saw during the presentation, you can even maintain the soft tissues, the shape of the soft tissues with the Maryland bridge. You can put the Maryland bridge.
What happened?
A little bit submucosal in touch, in contact with the soft tissue graft, and you can maintain that critical profile. You know, that is possible.
Exactly. Fully agree with you. So on this, we are in time. Right now, I think that Dr. Fadi Abiyama could prepare his presentation. So my friend, thank you for your presentation.